I don't think that's the correct one. Oh, wait. Well, hold on, Deb. Is that day 5 out of the TSAS one?
Yes, Steph.
Okay.
I think the Halloween question always throws us off because it's just a holiday that Christine really enjoys. So she likes to ask the question, regardless of the time of year.
Okay, so we will like I said, stay on for an optional debrief. So just remembering your 4 elements. There's some heavy stuff in these modules, and it might be activating. So if you want to stay on after to talk, or if you need to take a break at any time, please feel free to do what you need to do to take care of yourself. And if that means taking a break and taking some time to go outside or get something to drink or just, get away, please feel free to do so. Don't feel pressured to have to be sitting here through the whole through all of the training if it is activating to you, because we will be sending the modules and recording if there's any areas that you have to step away from. So just keeping that in mind. So I think in honor of Christine, we can do this poll. And I didn't set it up for this one. So if you want to in chat, talk about our Halloween, yay or nay, and best costume you have ever had. Shayla, Xena, Warrior Princess. Oh my gosh, that is like the perfect Halloween costume for you. She is totally Xena. Anybody else? Princess Leia. Oh, we got some nays in there. Princess Leia. Bride of Frankenstein from Deanna. Let's see. Yay, the Ring Girl. A witch costume. I think I'm a witch or a vampire like every year. It's my go-to. Oh, Shawnee was a Eminem. Emily Witch. Daroa. I never really celebrated because my family never let me, but this year my dog showed out as the Princess and the Frog. Nice. Becky. Velma from Scooby-Doo. SC. Coraline. Oh my gosh, that's my daughter's favorite. Yay, Grumpy Smurf. Awesome, you guys. Spider Queen, a leopard. Sarah says yes, she loves to dress up. Witch, a flower, cute. And there's a couple nays. Pirates, awesome, you guys. Oh, Edward Scissorhand, awesome. June says, don't judge me, a pregnant nun, and I was at a bar drinking. My bump was so perfect that people really thought I was pregnant and drinking. No judgment. All right, thank you guys. So like I said, we're going to be talking about mental health today, and I will hand it over to Becky, who will be presenting this module. Thank you, Becky.
Thank you. And so I'm going to start off by saying many of us, I think at MUSAC, have been hit with a variety of illnesses. So forgive my voice and all of those things today, but you'll get to listen to it in a couple modules. So lucky you. But Shayla and I are going to partner up and chat with you all today about this module and about mental health. And I really think as we start to jump into this, it's important to remember I am not a mental health professional, right? Shayla is not a mental health professional. We are speaking about mental health from the perspective of an advocate. And that doesn't mean that there aren't different types of advocates, right? Like as mental health professionals, we can be advocates, that type of thing. But we're sharing this information today so that you can use it to maybe help inform places that you might make referrals to, be thinking about folks that you partner with, be familiar with some of the terminology so that you can maybe recognize some of the things that you're seeing, but knowing like this is not meant any of this information for you to be diagnosing anyone or anything like that. It's really from that, again, an advocacy perspective, like this training is based on, and to really think about and define the distinctions between mental health professionals and mental health advocates, maybe even, and the role of an advocate. And then we will talk as well about chemical dependency counselors and just some other professions that will intersect with advocacy when we're talking about mental health, mental illness, and mental wellness, right? And so I just wanted to kind of get us started and preface that. My name is Becky Jordan. I am our communications specialist here at MUSAC, but I have a background in advocacy work, specifically a lot around sexual violence and human trafficking, as well as a lot of work in community with teams and lots of different partners in community. So that is a perspective that I'll be speaking from today, and I'm located in South Dakota. So glad to be joining you all today. It is just getting started snowing here and very windy, so we're bracing ourselves for that. Shayla, did you want to? I know you've already been on training for a while, but.
Yeah, thank you, Becky. Good afternoon, everyone. Shayla Boma, Nisi Gosawin. I know I've been on, so I'll just say hi. And thank you for highlighting that, Becky, and really for highlighting that coming from an advocate standpoint and saying we're not mental health professionals, but really educating on how trauma may show up and really voicing that from a mental health perspective too, while carrying out services for folks who come through our doors or who are reaching out for resources and assistance.
Perfect. So we'll just kind of start out by talking about the definition of mental health. And I think, although it feels like things have gotten better in more recent years, like I felt like sometimes mental illness was almost like used interchangeably with mental health. And that they're two separate things that we're talking about, right? Like a person, we all have mental health and wellness. And mental illness may be something that we struggle from time to time, or that's a lifelong illness, depending on what the situation is. But what we're looking at here is the World Health Organization's definition, and they define mental health as a state of well-being in which the individual is in the state of well-being, realizes their own abilities, can cope with normal stresses of life, works productively, and can make contributions to community. And so essentially, kind of looking at mental health as you are able to be functioning, you have an understanding of how you are and how you're living in the world, and that you can, kind of like it says here, cope with the normal stresses of life. It's when we start to get into those situations or illnesses or times where we aren't maybe able to cope, or some other issues start appearing, that we begin to look at, is something going on? Is this a situation where myself or someone that I'm working with or that I know might need a little bit more help? Do I need to make that referral or provide them some resources because maybe their mental health is struggling, or they're struggling with their mental health? Next slide. So kind of thinking about that definition, what does that make you think of in regards to sexual assault, and kind of how someone's mental health might be impacted if they have experienced or are witness to someone who has experienced some type of a sexual assault or sexual violence? And so maybe in the chat, or if folks want to unmute, maybe let's think a little bit about how sexual assault can impact the mental health of, let's start with the individual. How could sexual violence or sexual assault impact an individual's mental health?
In the chat, Autumn mentioned feeling unsafe all the time. So yeah, definitely throwing you out of your everyday, how we talked about like our well-being and managing that through the day-to-day, you know, not feeling safe and how stressful and tired, like how fatigued that could make us, or just being on edge all the time. Omi mentioned change in focus of control. Janie mentioned feelings of isolation, feeling loss of self-agency, shame, depression, suicidal.
And I think here's where we start to see kind of some of the mental like health illnesses or diagnoses kind of coming up in here too, right, Shayla? Like people are talking about suicidal ideation, trauma responses, depression, like all of those kinds of things that someone might be diagnosed with as well.
So we talked about how sexual assault, the impact of health and well-being for the individual. How could it affect the family, or impact the family?
And I see Autumn's comment kind of relates to both lashing out at a family and people not associated with the trauma. So that's a great example of that individual impact as well as impact on family.
Thank you, Carrie. Generational trauma, cycles of trauma. Darcy said paranoid. Yeah, it's really fracturing the family. Family feeling worried and powerless, trying to protect your loved one. Thank you. How does sexual assault impact the health and well-being of the Native community? It's desensitized. Thank you, Autumn.
That's a great one.
Families feel helpless.
Did someone have a comment they wanted to share? Okay. Centering of abusers, making survivors feel unsafe, stereotypes, disruption of cultural, spiritual relationships when abusers are figures within the culture or community, lateral violence. These are great examples. And I think I mean, so many of these speak to that kind of like that holistic health, right? And so even when we're talking about mental health, it's about us as whole people, right? And thinking outside of just the individual, I think is so important when we think about how mental health and mental wellness can have impact. I loved that comment about desensitized. Like, you know, I just think of you know, we get so used to even just kind of, and I know we'll talk more about this, Shayla, but using some of these terms like just like interchangeably, or just throwing sometimes like words out, or like diagnoses is out, like, oh, this person, or I'm feeling this way, or all those kinds of things. And I think that does desensitize us sometimes to like what someone might be experiencing within their mental health, right? Like if, or even you know, where it's like someone is called crazy, right? Or if we say that things like that in the community, like all those kinds of stigmas and all those kinds of things can work to desensitize conversations around mental health in our communities. So these are great. Thank you. So these are just you know, kind of some of the common reactions that someone might experience when sexual assault occurs. And so as we know, some of these reactions might happen instantaneously, right? There might be an immediate reaction that we start to see. And some of the reactions that someone might have, or the experience that they might have, might come much later, days, weeks, months, years, decades, right? After what they might have experienced. And I think thinking about that too, in that just like, healing doesn't happen on a continuum, like how we experience trauma and violence isn't happening on a continuum. And so how each of our brains processes things, and what we are allowing in, our previous experiences, like we'll go into here, all of those things can impact so much of how we react to sexual violence. Thinking about, oh, go ahead, Shayla.
Oh no, I was just gonna continue on from someone how they already mentioned it in the chat. We talk a lot about self-blame, and the levels of fear and anger each person could differ in the way we internalize our assault.
And I even think about we've got kind of separated out by some of the reactions and what the reactions depend on, but they're so like intertwined, right? Thinking about like varying levels of fear, blame, anxiety, all those kinds of things, like that might look very different at, depending on the age that someone is when they've experienced an assault, right? Or how their family or their community responds. And so just thinking about how these things are so linked. Sleep disorders, or just like irregular sleep habits or patterns. That can be anything from, just restless sleep to things like night terrors to, all different kinds of things to do with our sleep, difficulty concentrating, those flashbacks, and then just general like emotional numbing. All of those are so directly impacted by, the victimization itself, right? Like when did it happen? Who was the perpetrator? Where did it happen? Did it occur in this home that I'm still living in, right? Is this something that I'm remembering years later that I blocked out? It's just it's I think mental health and thinking about its kind of connection to sexual violence is so interesting, because we could talk so much about just like how your neurons fire and all of those kinds of things about how our brain works, right? Like, and that's above and beyond my areas of expertise, but it is so unique to the individual, even when there are kind of these commonalities that we tend to see with survivors. But knowing that each individual is going to have their unique experiences. And I see, Sarah's got a comment here about working with someone who's afraid to leave the house, right? And so thinking about how linked our mental health and our mental wellness is to our physical health and our physical like feelings of safety, right? And so what we are telling ourselves, or what our brain might be telling us, can even be counterintuitive to what we might want to be doing or be physically doing, right? And so it can be very disorienting and isolating and all those kinds of things. And so these are just really great examples. Do the next slide.
So we talked about, I love how Becky mentioned, like how mental health, and then kind of how it previously kind of seen it being referred to as mental illness, and kind of really explaining it to. So on this slide, mental illness seen as a medical condition that disrupts a person's daily functioning, thinking, and mood and ability to relate to others, result in diminished capacity for coping with ordinary demands of life. And then a statistics on the right, 1 in 4 adults suffer from diagnosable mental disorders. So just keeping that in mind when working in with sexual assault and the high trauma, and how on top of, oops, sorry. Next slide, Deb.
So this kind of this slide, I think, gets more at what we were alluding to earlier, when we were talking about the ways in which we even speak about mental health or mental illness. And so, maybe we can just start out by in the chat. What are some words you've heard used to describe people with mental illness?
Crazy. Thank you, Shiloh. Autumn mentioned Whitco. Did I say that right, Autumn? Sorry. Whitco. Living in space, nuts, out of touch, dramatic. Thank you. Then our next question, what were you taught about mental illness growing up?
Well, and if I could say something really quickly before we move into that, even Shayla, is like the connotation of all those words that folks were sharing, right? I didn't hear, or I didn't see or hear anything like very positive. Most of them had some negative connotations to those words that folks were using to describe, or what you've heard people describe. And so I wanted to explicitly say that that the words that we often hear are negative when we're describing folks. So sorry to interrupt, Shayla. So things that you were taught growing up, I saw some folks said nothing, right? That they hadn't been taught at all about it growing up. That one, tired of hearing you're so strong. That's really a powerful one. That it's not real, too young to have stress, all in your head. You're too sensitive, buck up. Suck it up, that it was a myth. Mental illness is something that I have. However, I am not mental illness. I think it's important to use words intentionally. I have bipolar. I am not bipolar. Great. Awesome. Love that, Carrie. Taught that if you are seeking help, then you are faking and it's not real. And so isn't that so interesting, even just reading through those, to kind of compare again to when we're talking about mental illness in comparison to physical illness. If someone is saying, my arm hurts or my leg hurts, or, I'm experiencing some kind of physical pain, it seems that we as a society or folks aren't questioning that as much, right? They're going in, or they can see it. It's something that we can diagnose. Oh, you're bleeding. That must be painful. Or, oh, I can see that injury. Okay, I can verify it. But there's, this something around mental illness when we're talking about that especially if someone can't see it or doesn't know about it or isn't as familiar, it seems like that we get these kinds of reactions, right? Like it's not real, or you're faking it. You're looking for sympathy, or, whatever it might be. I think it's just very interesting to be thinking about. And so how we view mental illness in our Native families and communities, I see one comment here says that they were taught that mental illness, I lost the comment. Mental illness was only for white people or privileged people. Didn't talk about it and just assumed my family, my community were toxic, and I couldn't wait to graduate so I could run away. And what about access to care in our communities? Thinking about that and how we're viewing it, and who has access to care, what kinds of care is available or was available for you?
Thank you, Autumn. People afraid, worrying about being their kids taken away.
And again, like, would we have that same worry? Like I said, if you had a broken leg that you went in for treatment, would you worry that someone was going to come and take your kids? Maybe, because of all of the things, right, that we're talking about and learning about. But much less likely, I would say, than, if you're worrying about a treatment for a mental illness.
I really like, Autumn, the point you brought up, like that stigmatization and that fear is real. Wanting to reach out for help, but then in fear of maybe that results in your kids being taken away, maybe you'd be questioned at your place of employment. So the fear of stigmatization and the fear of the repercussions for reaching out for help, just with, and then I live in Havre, Montana, and the reservation I grew up on was Rocky Boy. And just thinking of, for like behavioral health, and really having to outsource and commute for behavioral health services, or the lack of support around at our medical facility. Sorry.
And there's a comment too from Jess that most care was offered by white folks who didn't seem to believe the victim, asking questions that add to the lack of safety, and then worrying about going to IHS and the gossip or information getting out. And so again, I mean, even in how where we might see some similarities, like there are unique experiences, right? When we're talking about and dealing with mental illness, specifically within our Native families and communities, and those stigmas, and those realities as well, right? And so kind of taking all of that into account when we're kind of diving into this conversation today. Next slide.
So on this slide, we'll talk about how depression looks as a result of a sexual assault. Like we talked about, difficulty concentrating, remembering details, a tough time decision making, internalizing the assault like it was your fault, having those feelings of guilt, worthlessness, the stigmatization about, we talked about the stigmatization of mental health and the fear of reaching out for resources. And in a tight-knit community, sometimes you're worried about word getting out, so feeling helplessness and hopelessness. We all talked about a hard time getting rest, feeling that anxiousness and fear, sometimes unable to leave the house, feeling irritable, especially with those, our loved ones around us, who we don't even mean to react that way or be with around, folks we really care about, but just with what we're dealing internally it just makes us irritable. Loss of our appetite, not getting rest, and how much that could even interact with already feeling depression. The toll our mental health could take on our physical side of things, feeling headaches, pains, thoughts of suicide. Next slide, Deb.
And so this slide is really looking at, again, like a specific diagnosis, right, that someone might receive if they're going in and being seen by a mental health professional. So clinical depression, sometimes known as major depression or major depressive disorder. It's not the same as depression caused by loss or the death of a loved one, that kind of a thing. It's a mood disorder. So feelings of sadness, loss, anger, frustration that interfere with everyday life, lasting for weeks or longer. And so, we're not talking about those down days that you might have, right? Where kind of you say, oh, I'm not, I'm not feeling myself today, or I'm kind of feeling, a little bit, under the weather, or, I am dealing with a loss. It's something more than that. Research has shown that it has no single cause, and though it oh my goodness, often involves the interaction of many diverse biological, psychological, and social factors. And I think that's always so important to be aware of too when we're talking about our mental health, is that there are outside factors that can add to what we're experiencing and sometimes even and trigger what someone might be experiencing. But there are also, you know, things that are superseding all of us, right? Those biological aspects of our health and wellness, as well as, you know, just what we've been taught and experienced and where we've grown up. All of those things come into play with our mental health as well. Next slide.
Post-traumatic stress disorder, PTSD. So in the US, we see more than 3 million cases every year. It's a response to experiencing a traumatic event, may include re-experiencing the traumatic event, flashbacks, nightmares, intrusive imagery, including a person to avoid the possible triggers, staying away from places, objects, people that remind them, feeling numb, guilt, depression, losing interest in activities. Other signs could be like easily startled, feeling constantly on edge. You know, we talked about that, feeling unsafe, and really what does that look like? Preventing us from getting rest, getting sleep, angry outbursts, from feeling irritable. Next slide.
And I think something to think about as we're kind of going through these slides as well is that these are all very heavy topics, right? And we know that there is a connectedness though with those of us who have experienced sexual violence. There's a correlation between some of these things, and there are places that this overlaps. And even thinking about PTSD and diagnoses, and sometimes I think, you know, I'm reading through all these comments that are coming in that there's so much that's not taken seriously. And so when we're looking even at some of these statistics, I think it is so important that we are doing as much and as early education as we can, and letting folks know that like these are the realities of what folks might be facing, but that there are resources available. And so when we talk about things like suicide, we know that it is a major issue in many of our communities. And specifically here, we're looking at youth, that suicide is the second leading cause of death for American Indian, Alaska Native youth 15 to 24 years old. Like, I remember looking at a chart just recently that kind of, I think it was from the CDC, and it had been animated. It was kind of showing causes of death over the years for folks, right? And just the incredible quickness that kind of death by suicide has risen in the last few years. It's just amazing, and especially in the cause of death, like for youth. And so again, I think it's something that's important, but I really wanted to stress that, especially in that early education and thinking of ways that we can be supporting the young folks in our lives, but all across the lifespan. And many who attempt suicide never seek professional care. And so I also think this is interesting too, because you may hear someone talk about it sometimes. And I think sometimes when we're with someone, or we're supporting them, or we're their advocate, you know, we want to be sure that we know what to do. If someone does talk to you about having feelings or having thoughts, or has a plan, right, about how they're going to try to carry out this plan, have resources available for them. Know how to talk to someone who's disclosing information, because I think that can be sometimes something really scary to disclose in general. And you want to be met with a reception that kind of meets that, right? That someone who is there for you, who's listening, but who's prepared, because again, we aren't in this setting as a medical provider, right? We're here as a support person. And so we want to have those resources available to us as well. And so, this high correlation between, suicide attempts, suicidal ideation, and sexual assault, we know that the research shows us that, right? We know that many folks who have experienced sexual assault, there is absolutely a correlation there. Looking at substance abuse as well. We know that there's a correlation between substance abuse and sexual assault. And so again, just kind of looking at how all of these things overlap, that strongest risk factor being when depression is not treated. And so thinking about who we can refer folks to, and I did see some comments talking about, folks not wanting to go to the hospital because they're being treated terribly, and all the other reasons that folks, may not seek medical help. And I know one of the things that we used to talk a lot about in our program was like, where are, the good ones, right? Because not everyone has training in sexual violence or sexual assault. Just because they are a medical provider doesn't mean that they have had as much training as you have had as an advocate, right? And so who are those places and spaces in our community that we can make connections with to kind of start to have some of those conversations too, and find those really helpful and supportive folks who will support survivors.
So now we'll discuss the symptoms and signs of suicidal ideation as related to sexual assault. Thinking and talking about suicide, having it come up in conversation or how they are feeling, starting to abuse substances, feeling no sense of purpose and belonging, like we talked about, feeling hopelessness, anger and rage, feeling trapped, withdrawing from not just their community, but from maybe their everyday activities are changing, recklessness, seeing them behave and act in a way they normally wouldn't, dramatic changes in mood. Maybe you just cannot be around them. They're just on edge. And we talked about, coming from an advocate sense and not a medical professional. So how to make a referral or having resources available just to support them. Suicidal, and when they mention their suicide and homicide ideation, when you notice change of eating and sleep patterns, when they're withdrawing from everyone, giving away things that are important to them. And especially if a survivor requests one, right? Reaches out for help. And we all talked about it, coming from that advocate standpoint, and that oppression lens and that discrimination and the harm that we experience at hospitals or anywhere, when we talked about people in fear of going to the hospitals or in fear of reaching out for help because they know the treatment that they will receive. So really advocating and being prepared to get them help and push back on that discrimination and really show up for them. Next slide. Sorry, my little brother played in divisionals and I'm like finally starting to lose my voice, so I'm like trying to drink tea so it's like not raspy and I'm coughing. I was cheering.
So we'll just talk a little bit about self-harm and self-mutilation. And, again, I think this is one of those things that, unfortunately, we see quite often with survivors that we're working with. I know we saw this, whether or not someone may let you know or let you see more than others too, right? But just some of these ways that someone might be coping with what they've experienced. And so self-harm or self-mutilation is a deliberate, usually secret infliction of physical harm, right? And so survivors might be using this to cope with the sexual assault or responses they're getting from their family or community, or just a number of things, right? And it's kind of that physical manifestation of that pain, that mental pain that they might be feeling, or that emotional pain that they might be feeling. And it's kind of providing this temporary relief. Many times it might cause permanent damage to the body, depending on what type of harm that they might be doing. And it's often associated with guilt or isolation or self-loathing, those kinds of things. And so again, it can be something that's very difficult to talk about, even if you notice and you say, hey, what happened there, right? That could be a very difficult conversation depending on what the context is. And so some of the things that you might see could be signs of cutting, signs of burning, could be biting, maybe them like hitting themselves, so bruising on the body, that type of thing, pulling out hair. That could be like even like eyebrows or eyelashes or, on their head, wherever that might be. Scratching or picking, sores on the skin. You might notice just like eating disorders or substance abuse as well. But when you look at this list of things, like this in of itself may not be indicative of someone that's self-harming, right? This could be from other things as well. And so again, I think it's important that we do approach conversations in a respectful way as well, because we don't necessarily know what might be going on. You might see a bruise on someone, and you want to be respectful in the way if you're going to be asking questions about it that you're asking, because you don't necessarily know what's behind that, right? And you could be opening up a lot. And so just being cognizant, but also being aware if you're seeing things. I know we used to see a lot of cutting on the arms, of course, like the upper thighs. So like when it was warmer out in shorts and things like that, or on the legs, often in places where someone could hide them if they wanted, but not always, right? And so again, just things to be looking for, and offering resources and support as well. Next slide.
And if anybody you're working with, or even anybody if you're concerned for them being suicidal, don't be afraid to ask about it to them directly. As an advocate, that is like one of the greatest things, just to be there in person, knowing that you're there with no judgment, no bias. You're there to fully empower and listen. And if someone says they are thinking about it, validate what they shared with you and asking them about their plan, and if they even have one in place. And then really, what does that plan mean? Do they really do want to carry it out and kill themselves? And then really remembering that self-harm and suicide are different. Someone can self-harm without the intent to kill themselves, or vice versa. Reaching out for emergency help, 911. There is a culturally competent crisis counseling that we do have listed, texting native to 741-741. And of course the Strong Hearts Native Helpline. And then the 1-800 National Suicide Prevention Line.
So this role clarification piece is really kind of alluding to what we talked about toward the beginning of our time today, in the role of an advocate versus the role of a mental health professional. And so as advocates, we want to be well informed about maybe some of the warning signs or things that we could be looking for, resources that are available so that we can make referrals, where to report if someone does make threats or attempts, or has, expressed threats of homicide, those kinds of things. But once we've made that referral, or once someone is going in to see a mental health professional, that's where they can really get into maybe some of the details and hopefully assess what's going on and access care as well, and treatment or medication or whatever that might look for them. And so that's where they can ask maybe some of those direct questions and get more information, ask about, different scenarios and things they might be wondering about. And really, again, you want to, especially in situations where you're making that referral, we want to make sure that we're referring them to someone that's a safe place, someone who has information, someone who is going to listen and be non-judgmental, and really be survivor-centered, right? And listening to what it is that they're needing and they're wanting, and helping them make a plan for treatment if that's what they decide to do. But whatever that is, that plan is based on what that individual needs. That's helping to keep themselves safe, or others around them if there's those types of threats happening as well. And being really clear in that. But in your role, you know, being supportive and really helping them locate those great resources in community. Next slide.
Chemical dependency, characterized by an addiction to a mood-altering chemical, both drug addiction and alcoholism. Many different signs, you know, both physical and behavioral, that indicate a person is using. Each drug has its own symptoms or side effects. And you know, common signs of chemical dependency: drinking alone or drinking in secret, hiding drugs and alcohol, the physical need, experiencing withdrawal, inability to function at home or at work, and experiencing issues with the law, sudden change in behavior and mood swings, and lack of rest, you know, unable to have consistency sleep patterns.
And then again, just thinking of our role as an advocate versus the professional chemical dependency counselor. We're again focused on the safety and what the victim or survivor needs or wants. And so we're going to be building those relationships ahead of time, taking opportunities to educate their staff about sexual violence and some of the dynamics that folks might experience, but ultimately making that referral. And then they are the ones who are, you know, making those assessments, figuring out what might be available for folks, and really helping them make a plan and set goals if that's where they are in their journey at that time, right? Because the thing I think too is that at the end of the day, the survivor is the one leading. And so we can make the referral, the counselor can assist, but the survivor ultimately needs to be the one who is ready and is at that point, and maybe at that point many times. And then there may be times when they're not ready to seek that help, right? But we are there to continue to support and provide that information. And then if any additional referrals are needed, like for emergency services or inpatient or those kinds of things, that professional counselor can help them make those determinations. Next slide. I think we've talked a lot about, again, the difference between advocates and then mental health professionals. And really, you know, we're supporting, we're helping support survivors and, you know, helping them maybe find the positives and provide places like support groups where they can work through some of these things, provide some education and information for them. You know, offering, you know, another supportive person that they can add to their network, where they can come in and, you know, visit with us and just kind of check in on where they are, where when they're working with a mental health professional, it's probably going to be in a more formalized type of way, right? They might have a case plan that they're working on. There might be, you know, some kind of maybe benchmarks they have to meet. There might be medications involved. There might be other types of things along with that plan, goals or treatment plans that they might develop. They might be receiving diagnosis within that. And so that may be a positive or negative thing, right? That may be something that they may even come back to their advocate for support around, like, you know, I've been diagnosed with this, or they don't believe me if that is the situation, right? And I know that I'm experiencing this, but I can't, you know, so that can be where you might see, you know, survivors looking to you for even that additional support while they're working with others as well. And really, you know, providing what you can as far as advocacy around that, I think can be important too, in the context that makes sense for you. And that the mental health professional in that situation is really going to be focused on the needs of that individual, right? How can they help that individual? You know, where sometimes an advocate may still be providing some support to even family members, right? Or others who are kind of supporting that victim and survivor, that health professionals really focused on that survivor at the time, seeing them like in more of like a patient setting, and providing that medical care that they might need at the moment. Next slide. So this just kind of further continues what we've been talking about. And I really do think it is important that we explain our role as an advocate, like what we can or can't do. And so I think even again around the language that we use, I hear one of the things I hear a lot, terms I hear a lot used is like PTSD. Oh, I have PTSD from that, or I have this, like that is a diagnosable disorder, right? And so sometimes we're even using these terms like in ways that might not be appropriate, but it depends, how a survivor is using terms might be different from how we might be using them, but we're not diagnosing anyone, right? We're certainly not going to go and talk to someone else about, well, I think this person has this, and this, right? Especially if we're not a mental health professional. And so we're listening, we're believing, we're supporting, but we are not making those diagnoses. We're getting them referred on to the folks that they need to get that professional support. And we're really there to provide support and assistance when and if survivors need us to do that in whatever way that they ask, however that makes sense in the role that we might be in with them or the relationship. Next slide.
And so this talks about when to make a referral to a mental health professional. Of course, when the survivor requests, and then when the warning signs, when you're seeing suicide, when you're hearing and seeing suicidal ideation and hearing homicidal ideation, and we talked about the difference between self-harm and suicide. So really looking for warning signs such as self-mutilation, cutting, and then talking about harming themselves or others.
So again, survivors should be the ones in the driver's seat. And so what we're looking at here is a list that's looking at different mental health professionals, holistic professionals, medical professionals, and then our traditional healers and spiritual guides. And I think that one of the most important things, so you might have a referral list, right, at your program that you kind of tend to go to and you look to, and this is who we want to send folks to, but I think it's important that you take the time to kind of vet and have some relationships with these folks. And if you don't have a relationship or you haven't spoken to them before, let survivors know that, right? If it's a list, I see like under our holistic professionals. So, I see dentist there as number one. You may not have a relationship with every single dentist if that's what they're needing, but you can provide them a list and say, okay, we know that this clinic does this, but I'm not sure about these. Like, it can be so helpful to be transparent in those situations about what you do or you don't know, because you may also say, oh, I have a great relationship with this dentist, and if I could get in there, if I could get my kids there, I would definitely try, because those things do matter. And I think it helps with that warm handoff, right? Or as much as you can help, like make a call or do whatever it might be. Providing that support is important, because there are lots of places that we might be making referrals out to. And I think the more often it can be a warm referral than just kind of oh, we can't do that, here's a number to call, right? We don't want to be doing that in this work if we can help ourselves. And so we've got a whole list of folks like clinical psychologists, therapists, psychologists, other types of counselors, all different types of people. We know that mental health services continue to grow. And so just really trying to have as robust of a list as you can. Those holistic professionals, I mentioned dentists, but homeopathic, massage therapists, acupuncturist, herbalists, aromatherapy, like thinking broadly about what someone might want to access, and who they might want, helping provide their physical and mental wellness. Other medical professionals, so not just doctors, but nurses, chiropractors, their OBGYNs, who else might be working in those medical settings that you might be providing referrals to. And then, of course, our traditional healers and spiritual guides. And I think we have a whole session, I don't think you've gone through it yet, where we're talking about more in depth about, spiritual leaders, of course, in different contexts. But, just again, like if you have connections and you have experiences, share those experiences, or share, maybe the experiences of others that you've worked with in a confidential way. So at least you can help someone to, be as informed as you can. And then I think on the flip side, if someone does come back and has feedback on these different folks that you've referred them to, I think that's helpful to process that. It may warrant that you have a conversation with them, again, in a confidential way, not saying, oh, Becky said this about you, but, we've worked with some folks and this is what they're saying, good or bad, because that feedback can be helpful for folks who are in times of crisis, right? We want to be making really good referrals when we can. Next slide. So we're always connecting our work back to social change. Sorry, Shayla, I don't know if I interrupted you. But when I think about, systems and social change in regards to this work, it's really about what we've been talking about. It's building those relationships and stepping into those spaces where we are also educating, right? Like we can help provide that training and information and resources, for our partners, right, who are in the medical field, and letting them know about what sexual assault looks like, what the dynamics are, all of these things, because it's all of our issues. They're seeing patients who have experienced this, just like we are seeing folks who have experienced sexual violence. And so the better relationships can be, the stronger our systems response can be. And that's where we're going to be going in the next session, right? Like talking about sexual response teams and the importance of having a multidisciplinary response. And so I really think that is crucial in having those relationships. And then just that ongoing public awareness, and the more that we're speaking about our mental health, as well as mental illness, the better we all are, because it's out in the open and it's safer to ask questions and have conversation. Next slide. Is that the end?
Yeah, I think that's the last one.
Perfect.
Yay, right on time.
Thoughts, questions, final comments on that section?
Did
Well,
you
thank
catch that last? I had to step away for a little bit, or I was answering an email. Did you see Carrie's question?
How do you build trust and open communication with a suicidal client when you are a mandated reporter? So, again, one of the things I think is being as open as you can from the beginning, right? Like if you're a mandated reporter in the very beginning, you're letting them know that, right? And throughout your relationship with them. And one of the things or the techniques that I used to use in advocacy was, especially when we would start to have difficult conversations, however you want to define those, right? To say, sometimes I would stop people, which feels counterintuitive, but to say, you are always welcome to share whatever you want to share with me, but I need to let you know or remind you, right? Typically, that I am a mandated reporter, and depending on what we talk about, I might need to say, and to let them know that. I think that is important. I also, whenever I could and was making reports, like especially in a situation we're talking about suicide or someone who might be suicidal, are you able to do it together? right? Are you able to make some of those calls together so that it isn't like, you're going behind someone's back and doing this thing, right? Like they're letting you know, or something about their behavior is letting you know this, and to say, is it okay if we call someone, right? Can we sit down together and make this phone call or make that connection? I always had a really good experience in doing it that way. And someone may, more often than not, folks seem to be more receptive when we could do things like that felt like a partnership. Like, I'm trying to help you get help, or it sounds like you're asking for this. I can't do that. I'm not qualified to do that, but like, let's get on the phone with someone who can, or let's go down and talk to this person. So, I don't know if Shayla or anyone else that's on the call has any other thoughts, but I had good luck in that way.
I agree, Becky. I mean, you tell them in the very beginning that there's certain things that you have to report, and it's always good to have a warm handoff, so you're not leaving them. And if you get them to sign a release, then they know that you're working together with that person that you're handing them off to, so that you guys can continue to all work together for her self-care or his self-care.
I really appreciate this. Yes, really telling them in the beginning that you are a mandated reporter, but then also, can't stress enough that warm handoff piece too. But then also, we talked a lot about, being an advocate and listening and having that support, creating that supportive and unbiased, unjudgmental. And so like even like using unharmful language, like when we had that group discussion about how have you heard mental illness, or like how have you heard this and how have you been taught. And so like really letting your survivor know too, like that you're there to support them, and by not using harmful language. So also just creating that safe space of destigmatizing mental health and suicide, and that they're able to share everything, but then also that kind reminder, like, I am a mandated reporter, but then also um how we talk about showing up, and then even offering physical safety, right? Like our body language, um, when we are told information. So really just having that safe, supportive space, free from destigmatization of mental health and like that harmful language.
All right. Thank you, ladies. That was amazing. Such important information for advocates. So I really appreciate even though Becky, I know I'm so sorry that if your voice is not up to, might not be up to par for 2 modules. I really apologize. But we're going to take a quick break, everybody, and we're going to come back to doing another module over SARTs, and looks like 2:20. We will be coming back in. Okay, so take a 15-minute break. Is that what it says on the agenda? 15? Just double checking. Yep. Okay, so at 2:20. Thank you.
Perfect. So just a couple things before we start. So does this module go until 3:20?
Yes.
Okay, thank you. And then did you create a poll for this, or are we doing this one in the chat?
I did create a poll for this one. I can get that going.
Perfect. So, welcome back, everyone. We are going to talk about sexual response teams. So we are just kind of, the poll is up, I believe, just kind of gauging your familiarity around SART, so sexual assault response teams, or MDTs, which would be multidisciplinary teams. So just go ahead and let us know. And this is a topic I love to talk about. So I am really going to challenge myself to stay at that hour, because there is a lot that we can chat about today. So it looks like very familiar, somewhat familiar, not familiar. So it looks like about half the folks have participated. So about half say not familiar, 30% or so somewhat familiar, and 17% very familiar. Awesome. Wonderful. Well, for all of you folks who are, well, for everyone, this will be great. And for all of you who are not familiar, this will be a really great overview. Like I said, there's a lot of information in this module. And so I'm going to try and briefly touch on different points throughout. But this is also an area that MUSAC does do some additional training on. And so if it's something that you're interested in, or you want to learn more, or your team wants to learn more, you can reach out to us separately for that as well. So let's jump right in if we're ready. Okay, so sexual assault response teams, what advocates need to know. So we are going to, or I'm going to, I guess, provide an overview of sexual assault response teams. We're going to talk about what their purpose is, how they can benefit survivors, who members should be on the teams, and then again talking about systems and social change. And like I mentioned in that last module, I really see SARTs as one of those places where we can make some significant systems change, because they're all about working with systems. So we will go ahead and get started. Next slide. So thinking about after a sexual assault has occurred, what kinds of supports do survivors typically need? So maybe as we're thinking about that, like, let's just go ahead and start chatting in. Like, you're thinking about responding to a sexual assault. What are some of those external supports that survivors need? Could be immediately, in the weeks or months after, or long term. Just start chatting in some of those supports if you can. So I'm seeing counseling, emotional support. Who else might they go to? Clothes to go home in? Absolutely. Community support if disclosed. Ongoing support with someone they're comfortable with. Medical. Protection orders, absolutely. SANE exams. And a SANE exam would be a sexual assault nurse examiner. We'll talk about that, but there's a lot of acronyms also involved with SART teams. So I will try to spell them out as well as say what those are. Medical, clothing, safety planning, victims compensation if they want. Shelter, yes, absolutely. Get wiped off with sage and help them if they're open to this. Yes, love that. So not just thinking about like only systems, but our traditional medicines and connections as well, which is part of why I love talking about SARTs here at MUSAC, because I think that's one of the great things is thinking about how we can bring in our traditional and cultural ways into this work as well, right? Because really at the end of the day, it's about partnership, and it's about thinking of how we can all come together as a community or as a system to create the best possible outcome or response for survivors. And really at the core of the work that a sexual assault response team does, in my opinion, there are usually two goals, right? That's victim safety and offender accountability, right? Because we're looking at SARTs as really kind of a culmination of the system's response. Now, of course, I know that that response is not for everyone. Unfortunately, in many of our communities, it's not built by everyone. And so that's some of what we're going to talk about in our time together is thinking about ways that we can improve our response as a community and as a system, so that we have that best possible outcome and that we do see accountability happening. Go ahead, next slide. So what is the sexual assault response team? I kind of alluded to that, but really it's a circle of people, right? It's folks who are coming together, they're bringing their knowledge and experience, and they're really trying to create the best support net or network that they can for folks who have experienced sexual assault or sexual violence. They are a multidisciplinary team. And so that in the beginning where we saw MDT, some communities will refer to them as an MDT. And that's basically meaning folks from many different disciplines who are coming together to create a stronger, more collaborative response. And then they can also be a vehicle, if you will, a place to build relationships, to be learning together, improving policies, bringing back feedback, good and bad, all those kinds of things that we want to do when we're trying to do really strong collaborative work. That's what sexual assault response teams are all about. Next slide. And so as I've already alluded to, sexual assault response teams can be called lots of different things. I will most likely be referring to them as SARTs for our time together. So SART, sexual assault response teams. MDTs typically are referring to maybe a specific situation. A lot of times around child protection, you'll hear the term MDT used. And some of these, again, are used interchangeably. They might be a protocol development team. Sometimes they're called a SARC or a SMART or a SART with 2 R's. It really can depend. Many times, especially a few years back, like when we started to kind of fund some of this work through different grants and those types of opportunities, you would see the teams reflecting the name of where the funding came from, right? So depending on where the money to start them came from, their name might be reflected in that. Some teams are purely for addressing sexual assault. Many teams, especially in smaller or more rural communities or tribal communities, may actually also address domestic violence and or trafficking as well. So it can really depend, and it's going to depend on what your community needs, and or how it might have been started. Like I said, that funding stream or that special project or that situation in your community that made you say, wait a minute, we need to get a team of people together. SARTs can focus pretty broadly, but they're usually broken down into 2 categories, and that's the systems focused. So they are looking at the big picture about how can we as a system respond better. And then the acute focus is usually like a case by case. So maybe a team was developed in response to a particular situation or case, right? Again, like a child protection team where you're doing casework. Sometimes you'll see this in like homicide cases, for instance, or those types of cases where you might have a task force that's specifically working on a certain case. But what we're really going to spend our time today focused on is that systems focused SART team. Next slide. So what's the purpose of a SART? besides bringing folks together and creating that space to make relationships, it really does serve as a place to do cross training and help encourage that coordination between disciplines. And so, why is that important? Because if we have better working relationships with one another in our community, we are going to have a better response for survivors, right? The more that we can trust the folks that we're working with, that we can understand, we can know more about their purpose and their role. And the same that we can reciprocate that, right? Like as advocates, we're helping to educate other partners in the system about what our role is and what we can do. We're just going to have a stronger response. And ultimately, that goal is really focused on a victim-centered response whenever possible. And so, you know, within SART teams, you may be developing protocol. You might be, like I said, addressing some of those concerns that are brought forward, and really just forming relationships. Many SART teams that I have been part of over the years met over lunch, or met, you know, in spaces where they could just have that time together, just as people getting to know each other and also doing this work, right? Because the thing about SART teams is that most folks who are there are representing different disciplines, which we're going to talk about. And so they might be there, like law enforcement is there in the role of law enforcement, right? Advocates there in the role of advocate, medical, et cetera. And so it's typically teams who are they're showing up in a role that they are paid to be in. Not always, but again, typically. Next slide. So a lot of these pieces I talked about, again, the purpose, I think it is important to mention that we're sharing successes there too. There's some really awesome things that can happen when we get together around a table and talk about how we can improve our responses. You know, looking through evaluations and bringing back feedback from survivors can be really eye-opening sometimes, right? And can be really uncomfortable even to sit together when some of that feedback isn't always the best. But when you get those thank you letters, or, you know, those times where you did a really good job, or it was a really great outcome, those are a great place where you can celebrate those successes together. And it just improves trust and community. When your community knows that you have a group of individuals who are focused on building responses, building policies that really do center around survivors, that means something. People see that, right? They see that our community takes this seriously, that there is a protocol I can follow, right? There's something that I can do if I need to make a report, or if I want to talk to someone. There's a system. I use system a lot, so I'm air quoting a little bit, but there's a system in place for me to seek help in this way if I choose to do so. And then another crucial role of our SART teams is just in that case review. So once a case has kind of come full circle, if that might be the way to say it, these teams can be a great place to kind of sit down and look at, where did we do really well and where do we have room to improve? And again, to do that in a group and learning together. Next slide. So who should be on a SART? It really, at the end of the day, depends on your community and the purpose of your team. Typically, it's going to have it's going to have someone from all five: advocacy, law enforcement, prosecution, medical, and then corrections or probation. Those are your kind of core members, if you will, of a team. If you're just getting a team started, you're going to want to have representation for each of those places, if at all possible. Really, and you see that kind of represents the full picture of what we think of as our system, right? Our justice system. But many other teams, or many teams across the country, will have representatives from places like schools, mental health providers, traditional healers or other culturally specific programs, youth focused programs. It really depends on, again, what you are focused on in your community. So when I've been parts of teams where we're focused on trafficking, you know, we might have a different investigator, maybe from law enforcement, who sits on that team, but we still have that representation there. And so again, the teams can be tailored based on your community. Next slide. And I should have said, anyone who has, like, please interrupt me or chat in if you have anything to ask or want to say anything, please. So some of those main partners that we talked about on the SART are medical folks. A lot of times that will include if you have a SANE nurse, so a sexual assault nurse examiner, and those are the folks who, I can't remember if you've already had the SANE module, but you're SANE, you have?
Yep. Yeah,
Okay.
we have.
Well, I don't need to explain. You're all experts on what SANEs are. But their role on the team and in the response is really focused on that evidence collection, that documentation, and just kind of what that looks like in the medical hospital setting, right? And so they're coming from that perspective. The law enforcement response, they're going to, again, be collecting evidence, looking at, you know, if there are issues along jurisdiction, kind of, you know, what happened, you know, immediately after the crime occurred. Advocacy, so many of us, helping inform, you know, and bring forth the victims and survivors' voice. Thinking about, is what we're doing trauma informed? What's happening in the crisis? Who, you know, are there other family members or other victims that we want to be also keeping safe? Helping provide that back and forth information, like from maybe surveys or feedback. Really, I think of advocacy as helping bring forth the voice of victims and survivors on the SART team, right? Many times advocates will facilitate or kind of be in a facilitator role on teams, but not always. But many times it seems advocates are in that role on these teams. Next slide. Then you have your prosecution. Your prosecution is going to make that determination once they've looked at the evidence, right, of what do we have here? What are we going to charge? What's this going to look like moving forward if we go to court or have a trial? And then also provide some feedback on maybe what might strengthen the response. And so what I mean by that is we would have prosecutors many times saying, you know, if we, you know, if law enforcement would ask these questions during the interview, if the nurse would gather this evidence or preserve it in this way during an exam, if an advocate would, you know, ask the victims or survivors about this thing, right? That could help make the case stronger, right? Because they're seeing it in a different light. And so they can be helpful in providing some of that input. Everyone from their unique discipline is showing up in a different role, and really representing kind of their agency most times in those spaces. And so I think, and we'll talk about this throughout as well, just remembering that because every person who's part of the team is from a different kind of lens, there are going to be different confidentiality and codes of conduct and HIPAA and all different types of things that we're going to have to adhere to, right? And so part of us coming together and having these strong relationships is learning and understanding each other's roles and responsibilities too. And so there may be times when a question is asked or something is brought to the group that someone at the table can't answer, right? Or someone at the table can't share. And so knowing and understanding that, you know, though I might be bound by confidentiality and how it looks for me as an advocate, a medical professional there may be bound by, like I said, HIPAA or something else. And so it's even going to vary with, you know, within the team, what you can share depending on the purposes. And so releases of information and all those kinds of things are so important when you're part of a team. We can go to the next slide. We touched on this, just thinking about, expanding that circle and who else might we need there. I know there are varied opinions on corrections and probation and kind of when and where and how they might fit in. I like to think of those first, so medical, advocacy, law enforcement as almost like your crisis responders, right, on your team, where your prosecutors coming in a little bit later in the response. And the same with corrections and probation and some of these other partners, they're tending to come in a little bit later in the response, typically, right? And so what that looks like may be slightly different. I've even seen SART teams that will have kind of a core meeting of those three entities, and then a larger group meeting that includes their mental health professionals, leaders from their local faith groups, whatever that might look like, and kind of go out as needed. And some work might happen in those small groups, and then some of the work might happen in the larger groups. And I think sometimes that can come into play, especially when we're dealing, like I said, with things like confidentiality, talking about evidence, investigation, those kinds of things, because there may be information that the team wants to talk about or procedures the team wants to talk about that they don't, for whatever reason, we don't want the whole community knowing about all of the details, right? And so just like interview techniques or, those kinds of things. And so again, it's just thinking about what the purpose is of your group and what the work is that you're trying to accomplish. Sometimes people are just brought in, for a temporary time to help educate, and then, they're off of the team. So, it's just kind of thinking about what that needs to look like based on where you're at in the evolution of your team, even, which we're going to talk about. Next slide. Oh, I see a question here. So why is corrections and probation included on a SART? I don't know if I answered that or kind of alluded to that, like that they're coming in later. So where they might be helpful is in similar to the prosecution, where they said, well, if we would have had or if we would have known, it can be helpful for probation to help inform like processes. So like, why is it important that someone knows if someone is released from custody, like those kinds of things, helping to inform those situations. But it can be also difficult, like to your point, you're asking the question here, the victim might be on probation for something. Absolutely, that could be the case as well. So knowing that we're not judging the victim, right? And we're not talking about their specific case, it's really in helping inform like that overall process. Okay, cool. So continuous improvement. So we're always trying to improve. So one of the things I feel like a lot of times our SART teams get together and we say, okay, we're going to create a really great protocol for how we address sexual assault in our community. And we wrote this protocol and we have a great big binder and look at what we did. And then now what? Right? And life doesn't really work like that either. And so like our SART teams, they are cyclical. They're not linear. There is no end. We are continuously improving. So our teams may go through seasons. We're going to have times when we have, people who are super engaged. We're going to have a time when we've got a great champion in law enforcement. And then we have a time where we can't get a nurse to show up at the meeting, right? Like, and the same for, it just, things ebb and flow. And so keeping that in mind, I think is important, that a lot of what we talk about is continuous. And so it's always thinking, what do we need to do next? When do we revisit, maybe a protocol that we have developed? Like when do we come back and talk again about advocacy, providing that, that ongoing training. So this kind of plan, do, check, act, it just continues on. And staying, with scheduled meetings, those kinds of things, I think is important, because we can never do enough about educating even what each of our roles are within a SART. So, I think it's one of those things where, especially, we feel like really accomplished, like once we've got that protocol, but that's really just the beginning of a SART team is creating that together, though it's a very, very heavy lift. Next slide. So I really like kind of how this is illustrated because it helps us think about SARTs kind of in the framework of the systems response, but also in the framework of more of a traditional like governance or clan system. Because every person or discipline who is a member of our SART has a unique role, right? So just like kind of how we're talking here in the image on your right, like saying, oh, okay, this is my role. This clan's role. This is this clan's role in the community. We each have our own role. And so we're going to have, again, I talked a little bit about this, but different laws that govern what we can and can't share, different accountabilities even. You may be in a meeting as an advocate or as a director of a program, and you may be the final decision maker for your program. And maybe that nurse sitting across from you has to go through a couple other levels of approval in order to make a change in their protocol, right? And so even who might be sitting around your table, what they're authorized, for lack of a better word, to do, can be different. And so I think it's always important to not make assumptions, right? Like sometimes we feel like, oh, this person or this entity is just being difficult, but maybe there's something more, right? Maybe they can't make those decisions. Maybe there are things that we aren't aware of that are going to be impacted by what to us seems like a slight change, like, oh, well, we can just, ask survivors at this point in the process, and that should be easy to do. Well, that might have a rippling effect in another part of the system, right? And so again, why it's so important to be having the conversations around that table together, and bringing that back. I think being comfortable to both share when we have limitations, and ask questions when we don't understand maybe what the limitations might be of someone else. Um, this regular presentations from different disciplines here, this SART tip section, I think where that helps is, like I said, we used to go around in many of the teams that I worked with, and we would do a little, 10, 20-minute spiel once a year about this is what our advocacy program offers. This is what, we do when they come in for an exam. This is, what we do in our department, or this is how our department is structured in law enforcement, because people change, roles change, rules change. We don't always know about all the services that are offered. I learned so many things in those presentations sometimes, and you could even see connections being made where it would, we talk about, someone mentioned in the comments about clothes to go home. And, we talked about, oh, we, put together these care packages and have, clothes available and whatever. And we had a hospital in one of our teams who said, oh my gosh, we've been trying to figure out, how to get this to work. Well, to us, we thought we had done a great job of promoting it, and they just didn't realize that was something that we could help provide, was those like bags for folks to go home, right? And so sometimes, even though we might think our partners even know everything that we can offer, things get missed. And so those opportunities where we can just continue to educate each other are important as well. Next slide. Okay, so I'm not sure if folks are more comfortable unmuting and talking or typing in the chat, but we really want to think about our response to sexual violence, right? And when crimes happen. And so here we're thinking about like pre-contact, right? And how our communities maybe more traditionally responded when there was someone who was perpetrating crimes, right? Now, of course, I am not familiar with every single community's response, but typically we tended to see a more immediate response or immediate consequence, right? It could have been very violent. It could have been murder. It could have been, whatever it was. Exactly. Traditionally, we would kill them. And we just talked about this in another space I was in yesterday, right? And so thinking about that and what that means, right? Like that is, for lack of a better word, a systems response, a community response. And so how do community members, how does our community respond now? What happens when someone is either charged or accused or whatever, a second
Are you trying to be a medicine?
or someone who's perpetrating sexual violence, what happens in our community now? What happens to the offender, or the alleged offender, but I'm going to say offender, in our communities now? How do we respond?
Sometimes there's no response. It seems like people are afraid to report.
Absolutely. Because people just kind of brush it under the rug or don't do anything, it feels like. Janie says, now they're protected in our community and they're hired as leaders. They get put on a sex registry list. Yep, sometimes. What else happens? How do we respond? How does our community respond to folks who perpetrate sexual violence?
They stay numb. They push it aside.
So the community kind of just pushes it aside, ignores it.
Yeah.
Mhm. One of the things that I think is interesting, even here, I see their private vigilante justice. Even the wording on this slide, we have it says alleged sex offenders, right? I just think that's one of those things that's so interesting. It's like the one crime that we talk about offenders in this way. We don't say the alleged, intruder at my home, or the alleged robber or the what, but we say alleged sex offender or alleged perpetrator in acts of sexual violence. Let's see. To combat that, we're creating spaces where sexual offenders aren't allowed. Absolutely. We live in a small little neighborhood and all of our neighbors together created our own community watch group. I love that. Whisper campaigns. Yes. So what about our response to victims? How do our communities respond to victims when they come forward, if they come forward, if someone else tells their story? What does our community response look like for victims?
I believe they're not believed and their credibility is shot down.
Absolutely. Sometimes we try to censor them. How else do we respond to victims? Often blamed, ostracize them, absolutely. Not believe, fear of retaliation. So a lot of that kind of shaming, blaming behavior, right? It's not the time or the place, then there's never a time or place. Yes, I love that. And so I think even thinking about some of this in that, like where we're saying, okay, we may never talk about the offenders, or we kind of have a certain way that we talk about them. We're blaming victims and kind of pushing them from coming forward. So on both ends, we're saying we're not going to talk about the offenders and we're not going to talk about or believe the victims. And so there isn't that kind of immediate response, right? And I don't know necessarily what that would look like now, because for a variety of reasons, we aren't out killing perpetrators, right? But how can we think about what immediate responses we can develop that can hold those who perpetrate violence accountable? It's something to think about, right? We don't have to have an answer today. But some of these cases and these situations, if someone does decide to move forward and go through the system, through the criminal justice system, they can take months, years, if ever, right? if ever is resolved in that way. Next slide. People don't want to believe the victim. Yes, thank you. So we're going to move into talking about what guides the work of a SART. And I would argue many of the things that we just kind of were calling out, right? Those realities, because they are realities of the communities that we're living in now, and that both offenders and victims and survivors are living in. Those realities are what guides our work in our SART teams. Next slide. And so when we're coming together as a team, I really love Jolene, who's on our staff. She does such a great job speaking about it in this way and thinking like, what are our shared values, right? So here we're using an example of the 7 grandfather teachings, right? That we have, bravery and honesty, wisdom, love, all those kinds of things. We're bringing all of these together, bringing our full selves when we're coming around the table. Like, why are we coming together? Why are we doing our work? What are our values? What do we care about? Those conversations are important when we're doing work as a SART team, as a coordinated response team. We need to have conversation about our values. We need to have conversation about, our mission and why we're here, and what does success look like, and how will we communicate effectively, and what does it mean to be brave in this space, and what are the things we want to learn, and what does it mean to speak truth, and all of these kinds of things are important because we're coming together and we want to be coming together in a good way that promotes authentic relationships and strong responses. And so I think, thinking about what that looks like for your own team, whether you're using, this lens of the 7 grandfathers teachings, or you're using, whatever those other values that you've identified, but it's an important conversation to have when we're doing this work. Next slide, please. So what do survivors need from a SART? So we've got, I'm also reading the comments while I'm looking here. So when we think about, if we think about our SART in the context of the medicine wheel, right? And we've got the whole medicine wheel, and we need all of these, we have all of these parts of ourselves, we're whole beings. The same can be said for what's needed from a SART. We need to be able to support victims and survivors in all aspects of whatever it might be that they are experiencing. There isn't a one size fits all approach, and every survivor is going to have unique needs. And so when we are putting together protocols or talking about our community responses or kind of figuring out what that will look like, these should be guidelines, but they shouldn't be so harsh that they are dictating, right? And that being said, we know that there are certain situations, right, where we have to stick maybe more closely to, for example, there might be a protocol that says you need to take your photos in this certain type of way, right, if you're gathering evidence, or close the bag in this certain way, right? That's not what we're talking about, right? And even there may be situations where we need to, for whatever reason, or we did, gather information in a different way. But as far as like how we're working with survivors and how we're moving through a case, there needs to be room for the humanness of it, right? And specifically, and we've been doing a lot of work around this across the country, is really looking at what are the needs of Native survivors, right? What is that? How does that look different? How does it look different in your community? How does it look different for those individuals maybe who are working with, tribal communities, or who are working with Native survivors, or who are working with, federal law enforcement agencies, like how do all these different entities intersect, and how can we come together in a way that really is victim centered and kind of sets the bar or creates a situation where we want to continuously improve, right? We want to learn from those mistakes that we are inevitably going to have. All of us makes mistakes, but those mistakes have impact, and they impact real people's lives, right? We are doing this work because someone has experienced sexual violence. And so when we do make mistakes or when we do mess up, it's also on us to take ownership in that. And so really just kind of, you know, staying on top of what's happening, taking that information in, identifying those resources, you know, all of those kinds of things, and that accountability. Survivors need accountability from our systems, right? And we can get that or get support around that in the form of our CERTs. Next slide. So again, this is just kind of looking at how, you know, ways to support survivors as a SART team in other ways. That trauma-informed lens is really so important. And I would even say, you know, kind of these 4 bullets here, the trauma-informed, survivor-centered, that everyone has a part, and that responses are culturally appropriate. Like those are 4 key points that you can plug right into your team or your response and really start to look at that. Like, what does it mean for your SART to be trauma informed, right? And what does that mean for survivors? What does that mean for your community? What does that mean, you know, in your, you know, in each unique discipline? What does that truly mean? And when you look at your response, right, whether that is like philosophically looking at how you respond or looking to a protocol that's written on paper, how have you, you know, how are we weaving in trauma-informed responses? And how are we kind of, you know, not just having on paper, you know, we do this, 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 and this, but really doing that if that's what we believe, right? Practicing what we say that we're going to do. Same thing with survivor-centered. You know, what are the strengths of the work that your part of the system does? What are the ways that you can be supporting survivors and really centering their needs and their feedback in developing whatever your response is or needs to be, or improving what it has been. Thinking about how you're going to be supporting each other in the process. You know, like I said, kind of creating those spaces for learning. How are you keeping your staff informed? So sometimes what can happen is there might be a change or something that happens in the response. For instance, you may say, okay, you know, moving forward, we're going to call an advocate every time someone comes to the hospital, right? And you've made that commitment at your team, but it doesn't get back to all of your staff, right? And so then we see, well, last time no one called me, well, I didn't know, right? That little thing, that communication piece can create a huge rift in things. It can create, you know, a situation where someone maybe doesn't have that support, like all those kinds of things. And so really thinking about, you know, how does that information get communicated, you know, to all folks on the team? And the team is not just those 5 people around the table, right? It is also all of their team who's part of their, you know, agency and organizations as well. And then again, how, you know, is your response culturally appropriate? What does that look like in tribal SARTs? And again, it might, you know, differ depending on where you're located. What does this look like in rural communities? You know, what does it look like if you're a non-tribal SART? What about other cultures who are part of your community and entities, right? What is our response created in a way that, and not only, although many teams do this, not only in an addendum, right, that says, this is how we serve this population, and we have a couple pages, and this is how we serve this, you know, I'm not talking about only that. Like, yes, that is important because it shows that folks are working, but we really want to develop responses so that all individuals in our communities are getting a response that meets their needs, as opposed to like having to say, oh wait, okay, so you now I need to do this and this and this, right? But it's kind of a both and in some scenarios. And so again, I've seen some protocols, well, they'll have 30 attachments that really go into the details of what and how they're serving different communities within their community, right? And different cultures in their community, and how they're making different kind of determinations and all types of things. And so it's thinking about, that we're developing a robust response on the front end as much as we can. And when we see gaps, that we do what we can to address those gaps as well. Next slide. Okay, so what do advocates need to know? So so first of all, I would say find out if your community has a SART team, if you don't already know that, right? Or is there something similar in your community that already exists? Like I said, it may not be called a SART, it could be called something else, but is there a place in your community where, advocacy, medical, law enforcement, those key folks are talking about their response to sexual violence, to sexual assault? Is that happening somewhere in your community? And if it is, are you a part of it, or is your organization a part of it? And if not, either why are you not a part of it yet, or now, or whatever it might be, or why is it not being discussed at all, right? So it's almost like a little mini assessment, if you will. And then thinking about, what for both of those scenarios, what does that mean, right? So you may have a team that's been in existence for 30 years, but they only meet once a year and they have an old protocol on the shelf and that's what they think they go by, right? Or you may have a situation where you've got a couple champions who are concerned about this, but maybe haven't like pulled together that core group of people to start kind of working together, right? And so it's important to kind of see where things are and have some conversations. I did see that Steph shared in the chat some resources. There are so many resources out there about SART teams, and really helping you to kind of have that conversation, bring up questions, like look at the structure if you have a team, or look at maybe creating one if you don't. There's so many resources out there. And I think for advocates, it's just really important to know that number one, teams like this can exist and be successful. And number two, that there's a ton of research and resources out there that you can have access to, that can help you, get started in those conversations, including, like I said before, even reaching out to MUSAC or other organizations to talk more about these teams. Next slide. I'm not sure if we missed one or not, but I will just, okay, perfect. So, we kind of touched on this, throughout, and I really think it is important, and especially, in kind of revamping or recreating or reimagining our teams, like we think about how we can and where we can integrate some of those traditional responses in our current response to sexual violence, right? And so you might see, when we think of like these mainstream systems or responses that were really centered around the case, right? And our goal is making sure that, it's victim centered, and they're participating, and that's happening. that things, kind of are like, we're looking for facts, right? And we're moving the case, like even it's here in air quotes, it's the case, and we've got the investigation, and there's a trial, and all of these kinds of things, and that we have to have that victim participating to make this case. But kind of thinking in that in like a really community centered more traditional focus of like, how do we circle around that individual and their family and their support systems? Yes, victim centered, but that accountability in the sense of the whole, right? That if I decide for whatever reason that I don't want to make a report or continue through or go through a court trial, right? That can still be okay. And what is our community's responsibility in that kind of accountability piece, right? And how we view and how we respond to sexual violence occurring, kind of I don't want to say as opposed to, but it really is as opposed to like, well, you weren't there, and so we couldn't make the case without you, right? Why, and how do we build a response that really centers around that community stepping in and saying, we know this is happening, we are not okay. This is what happens in our community when this kind of crime occurs, and this is how we approach it, right? Obviously, still centering the victim and survivors and their family in that response, but really in thinking, it's a community responsibility. So does that mean developing programming if we need? Does that mean, being really kind of clear on what accountability is going to look like? All of those different pieces, and kind of shifting that mindset from, if we don't have this victim, we don't have a case, right? And then that's the end of it. Like, that's just a tiny, tiny, tiny little piece, if any, of so many people's situations. And so really kind of just changing, where we're spending our time and investing can make a huge difference in the outcome for so many, and just in how we approach what an effective response is. I wish you could see me, all of you. I mean, most of you maybe can, all these air quotes. There's so many when you're talking about systems, I think. Next slide. So just kind of in closing, just kind of, taking some time to think about, again, opportunities for systems change. We've spent this whole last hour, you've spent it kind of listening to me talk about systems, but, SARTs can be a really powerful tool to help improve all of our work. And so when we're working together, thinking about, as an advocate, as part of that team, what are some ways that you can be supportive? And so we're looking at our medical responses. If you're seeing situations where, maybe there is a lack of training or preparedness, let's like have a conversation about that. This logistics, I love this, sometimes, I I just think about so many times in a medical setting where it's gone great, but then also those times where it's gone wrong, right? Where it's like someone is thirsty and they want water and they say, "Oh, no, you can't drink anything. We have to preserve the evidence," right? Or, "No, we can't give you a Tylenol for your pain because we have, all those kinds of things, right? Like, let's have a conversation and examine some of the ways that we provide care, right? And so even, like looking at that and talking through that with our partners in the medical field, and thinking about like, are there ways that we can meet some of those immediate needs, that we can still, do what it is that we're here to do, if that is gather evidence, right? But at the end of the day, it's about making sure that they're safe and they get the medical care that they need. What do the waiting areas look like? Are there private areas? Just all those kinds of things that you might see in your role as an advocate that you could help bring forward to folks who are from the medical field and maybe not seeing them in the same way. So you can kind of support in that way. So bringing those concerns back to the group. But then I think also, meeting and having conversations, being familiar yourself with the facility that you might be going to. Just kind of having an understanding about what an exam is going to look like all of those things. It's doing that learning on the front end for yourself as an advocate as well. If you might be supporting someone during an exam, that can be a really scary time, right? And so the more familiar that you can get ahead of time, it just helps create that safer space for whoever you might be there supporting as well. Next slide. So with our partners in law enforcement, one of the ways, the thinking about gaps that you might identify, putting a lot of focus, or what feels like a lot of focus, on the credibility of the victim, right? And so really, maybe there's a situation or an interview where there's a lot of focus on if they were intoxicated, or if they were at a party, or what specifically the crime was that was committed, those kinds of things, right? You could see how those could be perceived, or by survivors, especially if they're being interviewed or whatever might happen. And so again, a situation where many times advocates are going to bear witness to seeing how interviews happen, right? And you're not in the seat of the victim, but you're there kind of watching what's happening. And so you can help identify those gaps, and maybe even help inform, how questions are asked, or again, when they're asked. The same could be said here. Are we meeting their physical needs first, so that someone is in a space so that they can give an interview? Do they need to give that interview right now, right? All those kinds of things. Same thing, reporting gaps that you see, making plans for maybe future training, or just having conversations about the whys. I think sometimes we get so short-sighted because we're just used to doing things like we do, that we don't see other ways or opportunities. And so again, it may just be as simple as, can this person just have, a few minutes to collect their thoughts, or to, lie down or go have a cigarette or whatever they need to do, and then they can finish that interview, right? Those can make huge differences, and can just, they may just be an oversight, or it may just be, like I said, a way that they've practiced, and so they're just used to it. Next slide. And then just the broader kind of community issue. I mean, we talked about so many of these throughout this time together, and how our community might be responding to victims and survivors. And so I really think as advocates, we have a great opportunity and responsibility to really get information out in our communities. And it's so powerful when we can do it as part of a SART. Because I really think of all of us as members of our SARTs as advocates too, right? Write those letters to the editor, put out information about public awareness and education, talk in your community, let community members know, like, we take this seriously and we are going to do something about it, and we want change. I think that's really what helps to bring that change. And the more we talk about it, and the more we let folks know what's happening, and kind of eliminate some of that mystery, I think the better, right? It's scary to reach out for help. And so the more that we can kind of, as a system and as partners, help to break down some of those barriers, I think, the better results we're going to have. And so when we're working all together, I think that some pretty amazing things can happen. And so I think that is about the end of our time, or just past. But any thoughts, questions? Probably need a minute to digest. That was a lot. Perfect. Well, I appreciate it. And like I said, if you have any questions, please feel free to reach out. I believe you all have another 15-minute break. Don't know if Steph or Deb are coming on, but so what would that be?
Yeah, that would be good, Becky, 15-minute break, and then we can finish up the impact of sexual
37,
civilization.
37 after roughly. Thank you.
All right, it's 2:35. We're not going to start for a couple more minutes, but I am loving reading your responses in the chat to this great poll, Places I Feel Calm. I'm noticing a lot of water themes here. This is great. I'm a Cancer, so as a water sign, I very much resonate with that. Okay. Well, good afternoon, everyone. This is Ingrid. I'm the National Policy Director at MUSAC, and I am so excited to be back with you all today. We have a lot of information to cover in a pretty short period of time, so we're going to get started here. We're going to cruise. So if you have something that is time sensitive, like if it's critical to the slide we're on or to the discussion we're having at that moment, please just come off mute and participate. I definitely want to hear your voice. I want to engage with you all. But like I said, we do have quite a bit of material to get through. All right, Deb, are we able to get to the next slide, please? All right, so we're going to be talking about the, are we starting with sexual assault victimization or the impact of sexual assault victimization?
The impact.
So module 13?
As far as I know, yes. Is that what we're supposed to be doing, or?
I showed 12 and 13.
Yeah, 12 and 13 are together, I think.
Okay.
Let me check.
I show that this is the first slide for module 13.
Okay, let me go back. Hold on. Ingrid, the one I pull up, it says 12 and 13 together. It doesn't say they're separate. And then that is the first slide that I pulled up.
That is just fine.
Okay.
All right, so we will start with the impact of sexual assault victimization. So of course we understand that there are so many factors that affect the way that folks respond or react to sexual violence, including, age, your support system, capacity to understand what happened, systems literacy, the type of abuse, etc. So in this module, we'll talk about some of the most common responses to the different types of sexual violence and some definitions that might help you to understand what you're seeing or what your experience. And we definitely want to center the reason why we are advocates, right? And that is to advocate for individuals, to work to end violence, to hold perpetrators accountable, and to change the conditions in our communities and in our society that allow violence to happen in the first place. Next slide, please, Debbie. Next slide, please. All right, so the impact of sexual assault definitely varies depending on factors such as who perpetrated the violence, whether that's perhaps a family member, someone known to you or to the survivor, maybe even just someone known in the community, the type and amount of force used, and then the difference here that we might get a little bit into is how the response might be the same or different if the violence is perpetrated by a stranger. Fear is often the most difficult emotion to manage. And those feelings of vulnerability, of course, are huge, regardless of who has perpetrated that violence. Next slide, please. So within your, if you have someone you're working with, or if you have a team there, or maybe just as a large group here, we can have a discussion about what type of sexual violence you're seeing most commonly in your community. Who are the primary victims? Who are you seeing most frequently as the harm doers? Are you noticing men, boys, or male identified folks experience sexual violence? Are they feeling like they can come forward and talk about that violence? And are you working with folks across the gender spectrum who experience sexual violence? And are you noticing anybody else who is targeted? Does anybody have a response that they'd like to share to these questions?
Jeannie wrote, oh, excuse me, in the chat, grooming young women into sexual relationships with adult men. See a lot in the Powell circle. Thank you.
Absolutely. Taking these spaces where predators know they're going to be maybe like unattended youth or people who are excited to be out in community, maybe without a guardian or someone with them. Absolutely. Looking for those opportunities to get people alone when someone might be vulnerable. See, there was another response here. Many are targeted. Absolutely. 30-year-old plus men with teen girls. So common. I was just hearing about this. Oh, a 10-year age gap is such a big deal when you're young, but when you're older, it's not that big of a deal, right? Trying to normalize what is actually predatory behavior. I think we see a lot of that minimizing. So I think what we're talking about is really, how do we notice, how do we observe, how do we correctly identify sexual violence, sexual assault, and the grooming behaviors. And that forces us to be honest about what we're seeing and to be able to say, yes, this is abnormal, or this is inappropriate. And once it's visible, we need to be able to speak about it and to respond appropriately as advocates. Of course, for every person who recovers from the experience of sexual violence, there are hundreds more who will become victims that we may never know about. I think about what we see now, what we observe now, say at our Wachipis, at our family gatherings, that our parents or our grandparents perhaps did not notice, did not understand what they were seeing. So I think that visibility is a huge part of resilience and an appropriate community-based response to sexual violence. Next slide, please, Deb. So common reactions we might see to sexual assault victimization can be simplified into two different stages. The acute stage, where perhaps an acute incident of sexual violence has occurred within the last day or a couple days, and the outward adjustment stage. And the outward adjustment stage typically happens if there's been prolonged trauma, or if the trauma happened enough time ago that the nervous system has started to re-regulate or attempt to re-regulate after that victimization. So in the acute stage, you might see that like dulled sensory affect with the change in memory function, disorganized thoughts, which a lot of law enforcement articulate as an unreliable victim, right? Well, her story is changing, or why didn't you tell me that detail the first time we talked? Nausea, vomiting, those nervous system reactions like shaking, uncontrollable body movements, that obsession to tend to personal hygiene. We might see like wanting to wash oneself, an absolute determination to get in the shower, maybe even obsessive hand washing, and an acute sensitivity to others' reactions, which can also be seen as hypervigilance. It's our nervous system's attempt to get safe. Like if this person is acting weird, I need to get away from them. I'm sensing danger. And in order to get safe, I'm going to comment on it or try to get away from you. And that outward adjustment stage looks a lot more like minimization, suppression, an analytical processing of the assault, and sometimes even that flight, which again, can be characterized by law enforcement or systems-based folks as an unreliable victim. Well, she just left town. We can't get a hold of her to get her back here to testify, or she changed her phone number again and no one can get a hold of her. And that does not mean that the survivor is unreliable. It simply is a common reaction. Next slide, please. That hypervigilance we talked about, difficulty with interpersonal relationships, sometimes can be startling to parents or like a family of origin if they say, we've always been so close and all of a sudden she doesn't want anything to do with me. Panic attacks or that startle response being heightened, which again is that activation of the dysregulated nervous system, those mood swings, including rage, and those sleep disturbances, which is really our spirit's way of letting us know that something's wrong and we need to be tended to. Next slide, please. Deb, could we get the next slide?
Oh, I thought he did, sorry.
Okay. So another important piece of understanding sexual assault or sexual violence is to understand that there are a lot of different ways that this can look in our communities, perhaps in the population that we serve. I think most people are pretty familiar with the term rape, date rape. Marital rape is a pretty outdated term, but you might still hear folks using that. A lot of sexual violence is lumped under the term intimate partner violence or intimate partner sexual violence, which might refer to non-consensual sexual contact within the context of a relation, like an intimate relationship. Alcohol or drug facilitated sexual assault. And you might not be as familiar with sexual harassment, bullying, female genital mutilation, or female genital cutting. You might hear FGM or FGC, incest, stalking, and then child molestation, which is kind of an outdated term for childhood sexual abuse. Next slide, please. Thank you. There's also these more difficult to define and even difficult to understand experiences of sexual violence. Exposure or like forced exposure to public masturbation, voyeurism, which is when somebody is watching you, somebody experiences sexual arousal or sexual gratification from watching another person or persons, perhaps in their private space, whether that be at home, in a changing room, public bathroom. Ritual or sexual or spiritual abuse, digital violence, which includes things like sexting, it seems to be just an obsession with acquiring nude photos, cyber stalking, revenge porn, pornography, commercial exploitation, which we often talk about in terms of trafficking, and then exploitation by professionals, which can include spiritual leaders. Also, a lot of times we're talking about folks who are in the helping profession. I don't know if anybody just saw this case that came out of Utah last week, about a nurse practitioner who had been molesting female patients, sexually assaulting female patients. And it turns out he'd been moved from clinic to clinic, and because of allegation after allegation. And finally, a woman sued him civilly because law enforcement was not taking her seriously, and his whole history came out. So that was a clinic-based medical professional. Next slide, please. So we can pause here for another discussion, thinking about those different types of abuse we just breezed through, and the types of abuse that you're maybe seeing most commonly in your community or in your program. How could you respond, and why? And why is it important to understand the different legal definitions of the type of abuse you're wanting to talk about? And what do you need to learn more about in order to provide more effective advocacy? Maybe there was a type of abuse that came up and you're thinking, I have never considered that as sexual violence, or I didn't even know that was a thing that is happening in the world. I need more skills, or I need some more support in that area. Does anybody have anything you'd like to chat about here?
Brenda mentioned oh, I'm sorry, that was from the last. Vulnerable elders exploited by PCAs.
Absolutely. Personal care attendants, I think that's a PCA. You think about who is most vulnerable, who is seen as the least sexually desirable, and therefore the least vulnerable to sexual violence in our community. Often the elderly, absolutely. And with little oversight, we think about how many regulations there are about the number of kids in a daycare in ratio to the number of caregivers. And we don't have that same expectation of care for our elders, precisely. I will say from my experience, one thing that surprised me in working in Nebraska was that we're having, like, there was a national conversation about affirmative consent in sexual violence, instead of just until someone says no, it's not an assault or it's not violence. And so my understanding of what a criminal act of sexual violence was not accurate, and that was quite the learning curve. Absolutely. Those slides were pretty crammed, so I think it makes sense to review them and let us know if you have questions later on. If a lot of grooming behavior, little oversight, children with special needs, absolutely. And then what does the system's response look like in response to children with special needs? Do we have appropriately trained forensic interviewers, that type of thing? Thank you so much for this insight. I am fascinated to hear about what you've all been experiencing. I think that will absolutely help shape future resources that we can put out, and I hope you'll reach out for more specialized training on those issues. Next slide, please, Deb. So what we might also experience is observing the impact of sexual assault on either family members, or what we can also refer to as secondary survivors. These effects are are huge, they're heavy, it's a very scary experience for family members or for support folks of survivors of sexual violence. And we don't really have good ways to talk about that. So let's have a conversation here today. Next slide, please, Deb. Okay. So I think when we're looking at what a family or a support system might experience when someone they love has been the victim of sexual violence, sometimes it can be hard to give them a chance to talk about their experience because there is so much energy focused on what the victim has experienced. And that's good. That's right. And that's valid. It's also important to offer those wraparound supports and services to family members. So we'll start with a critical look at a typical risk assessment form used in CPS or child protection. So CPS is often activated when there's a crime of sexual violence that may have occurred in a home, or occurred perhaps between folks living in the same home. Not always, but this can happen. So we'll go through this as a group and then we can talk about it in more detail. So each topic is assigned a score and then the scores are totaled, and they use a scale to assess the total risk. So one factor they score is the number of children in the home. So if there's 2 or fewer, there's 0 points. 3 or more children, there's a point assigned. Anybody want to talk about the implications for Native families on that one? Sorry, go ahead. Okay, next slide, Debbie. They're also going to assess the characteristics of a primary caregiver. They're going to assess their affect, perhaps their self-esteem, their visible parenting skills, that type of thing. Does anybody want to talk about what these implications might be for an average Native family? Yep, siblings and cousins living together. We have our way of kinship that is not clearly understood by non-Native folks. Also, maybe our affect is not easily understood by non-Native folks. I think most of us have heard, "Oh, you're so stoic. Can't ever understand what you're thinking," which might come across as apathetic or underengaged, unengaged. Next slide, please. They might assess the caregiver's response to the assessment. So if the caregiver or family member viewed the situation and cooperated satisfactorily, if they did not cooperate, they didn't seem to take the situation seriously. What might the implications be for a survivor of child abuse in this situation? I think most of us are we struggle to trust. Exactly, Janie, not trusting the social workers, of course. And how could we not have some trauma around this issue when these folks are in our home talking to our children? So ultimately, child protection workers want to keep the family intact and ensure that the child is safe at home. And your role as an advocate might be to prepare the non-offending caregiver to talk about trust issues and to talk about the importance of cooperating and what that might look like. Perhaps to validate trust issues, to say it's okay to feel violated by this person being in your home. It's okay to not trust them, but we need to talk about and understand the implications of what might happen if we are standoffish or if we come across as non-compliant. We know that it's devastating to have a child removed from our families. even if there has been a history of sexual violence or other forms of abuse, and that removing children can cause further harm. And so it's important to have these conversations and for everyone to be prepared for what an assessment might look like. Of course, this can also cause trauma to those extended family members, other caregivers in the home, when they're perhaps already thinking about their family member who's perhaps in the hospital experiencing a SANE kit. And here we are thinking about the children too. So it's important to understand all of that trauma coming together. Next slide, please, Debbie. You also might be asking about if a primary caregiver is involved in harmful relationships. So what does the partner, the boyfriend, that, kind of chosen partner look like? What is their interaction with the children? What's their interaction with their partner in the home? Next slide, please. So we just want to be sure that we understand how these systems are going to impact secondary survivors and the non-offending family members. It can sometimes feel for non-offending caregivers like they are the ones who are being scrutinized, victimization upon victimization within the family, right? But we want to encourage that ongoing critical thinking about what a system's response to sexual violence looks like and what is our opportunity to change the way that systems engage with our communities, the way that we prepare as advocates to teach and to support survivors and their families as they go through these many different systems that just appear out of nowhere when a crime has been committed. Next slide, please. So those opportunities for change can also be to keep the systems focused on the actions of the offenders and not the victim. I think it's a lot easier for folks to talk about the victim's behavior than the offender's behavior, because the victim is usually the one who's right in front of us. And they're the one who is usually more visible. We typically know more about the victim and their personal experience than the offender. And so it can be easy to slide into that focus. And we want to interrupt victim blaming language or behavior by practitioners, by systems-based folks, maybe even to remind a law enforcement officer, like she's not unreliable. She just needed to change her phone number for her own safety. And I'll be happy to support you getting in contact with her. There's a lot of ways that we can support a victim in their chosen way to get safe and to support them in engaging with the system in a way that feels safest for them. So has anybody had to do this to help paint a picture for first responders so that they might understand the harm that they caused, or that they might adjust their approach to a survivor? We also can employ these tactics or these skills with our communities. We can listen critically to the way that our community, maybe our family members or our elders, are speaking about victims of sexual violence. Even sometimes child victims are painted as dramatic. They overreacted, they didn't understand, that's not really what happened, that kind of thing. And we have an opportunity to say, no, like, we believe survivors, we believe children, and to shift what we're focusing on, to shift that whole narrative, and to change those hurtful responses, to say, how would you like it if someone said, we don't believe you? Or to say, can we put ourselves in her shoes? Can we try to understand what she's been through and how we might come together as a community? Has anybody else had to do this work or had the privilege to do this work to paint a picture for your community members?
Ingrid, I was even thinking too, you know, how you said paint a picture for the community members, and really interrupting that harmful language. And, you know, sometimes survivors of sexual violence may be ostracized in the community, or even children in any space, and really just trying to be supportive as like not only a good relative and a good community member, but instead of ostracizing or separating them, you know, having a kinder way of interacting or being supportive instead of.
Absolutely.
Thank you.
And yeah,
She said
Karen,
model empathy. Sorry.
yes. And it's so hard to do sometimes. I think that we have adapted the language and the tools of the oppressor, of the colonizer sometimes, and that we are quick to separate ourselves from someone who's in pain, for someone who's gone through something traumatic. And it's hard sometimes to be in connection with survivors, with victims, whether it's through our job or a friend or a family member, maybe just someone in our community, because empathy does require us to connect to our own soul, like to connect to our own spirit, with what someone else is going through. And I'm not saying without boundaries, because we do need to have boundaries to protect our energy, of course. But I think we also need to identify ways that we can interrupt these really harmful narratives that have taken root in our communities, unfortunately. Some folks had mentioned, I think a couple people had mentioned in the chat about POWs or our Wachipis being kind of dangerous. We have, broadly speaking, men who are grooming or who are predatory against younger females. And I think we need to talk about what it means that our cultural spaces are not safe for everyone in our community. Like that is a bigger conversation. Is there anything else folks would like to contribute to this? Is there anything that, based on our previous slides, that anyone would like to talk about, questions that we can revisit? And feel free to drop in the chat as well. All right, next slide, please, Deb.
Ingrid, I think that is the last slide for this module.
All right, well, you combined them into a really, really concise slide deck. That's exciting. A couple things that I did want to revisit. We had talked about like the wide variety of forms of sexual abuse and violence. And one of the crimes that was described was listed as child pornography. And I do want to emphasize that we're talking about child sex abuse images. And I know that terminology changes very rapidly. And so I want folks to know that if you're seeing that change in language, that is what people are referring to. Of course, that just reflects that we understand that a child is not consenting to participating in pornography, and those images depict the sexual abuse of children.
Ingrid, I just wanted to make one comment. I couldn't get to unmute when I was doing the things, but I do know that when I was a program manager, an advocate had come to me and she was having a hard time because there was a victim that had been raped like a few different times and people in the community knew about it. And she was having a very difficult time trying to get the police officers to believe that she was sexually assaulted. You know, that myth that it had, you know, of her reputation was overseeing the violence that had occurred.
I think you're hitting on something that is so common, and it's abhorrent to observe and to experience. I think last week we had someone drop in the chat about an experience where a medical professional said something like, "Oh, it's you again," or "You're back again," that kind of thing. There's a lot of ways that systems-based folks just kind of minimize what we're seeing in our communities, and what an opportunity as an advocate to interrupt even that kind of language. Debbie, what did you say?
Well, it was actually my advocate. Like, she was just coming in to debrief me because she was getting very discouraged and couldn't believe, even people were attacking the victim on Facebook. And, there was videos and like things being, like the victim was just attacked. There was no sympathy or belief, or like she was just being attacked. That's all that it was, by everybody. And then they were protecting the abuser, right? So it was, I mean, I thought she did a really good job. Like, she never backed down as an advocate, and she did what she was supposed to do for the survivor of sexual assault.
And what a gift that she was able to debrief with you within your organization, Debbie. Because I think sometimes we as advocates can hear things and we might think, there's no way this guy just said that, right? Or I must be misunderstanding. Or maybe we internalize things and we start to feel like, maybe it is hopeless, or, maybe this is just how it's always going to be, or, maybe this person did, maybe I'm thinking about the situation all wrong. And so to have that privilege to debrief in a safe space is essential to doing good advocacy work.
And
Yeah.
the other one thing I wanted to mention is, I don't think advocates realize that they're secondary victims too, because they're hearing all the stuff, and then they're carrying it with them. So if they don't have a safe place to debrief or let go of what's not theirs, they're carrying that secondary victim, and they're being impacted just like everyone else around the victim. They're being impacted. There is a question.
Go ahead. Is there somebody on the chat or someone live who wanted to ask a question?
Well, there's a couple of different stuff in there. Holly wrote, I've experienced with law enforcement responding to a survivor experience a mental health crisis and not being trauma informed. So they didn't understand immediately what was going on, and they escalated the situation. And then Becky says, yes, questioning ourselves. Did that person really say that? I must be misinterpreting. I fall into that often.
Right. The comment about the experience with law enforcement, I wonder, could you drop in the chat how you, as an advocate, maybe interrupted or responded to that situation? Because talk about a high stakes situation, especially if you're talking about someone going hands-on, escalating a situation when there is a mental health crisis. That can be so dangerous for everyone involved. I think we've seen that even sometimes in the news. Maybe while we're waiting for a response to that, Deb, when you were talking about our coping mechanisms, I think we talked a little bit about what might be coping mechanisms that we see in the folks that we serve. Those different trauma responses, folks who maybe change their patterns of life. They maybe change what they eat, their eating patterns, and then that sometimes those coping mechanisms, they're not skills because they're not healthy or helpful, but those coping mechanisms can look like even drug or alcohol use or abuse, suicidal ideation, self-mutilation, even sometimes other forms of violence. So I think it's important as advocates to understand, when does it go from a reasonable or normal response to something that might need a little extra support. like chemical dependency counseling, mental health counseling, or even intervention from like a crisis response team. And I think part of recognizing that in the people we serve is also recognizing our own coping mechanisms as advocates. I was just thinking last week about how I used to have to go home and take a nap every single day at lunch as like a 25-year-old. I'm like, I think I was deep in a trauma response as an advocate. That's not normal. And I wish I would have had some leadership to support me. Like Deb, you were talking about being able to debrief in that space.
And that's the scary part, right? A lot of advocates don't realize that they're your secondary victims. And what do we do to keep them healthy? And what happens when we have advocates that were sexually assaulted and sometimes get triggered, you know? So there's so much stuff that we need to do to keep make sure that the people responding are healthy and have a place to you know.
Riley, I didn't mean to call you out, but I just wish that somebody had talked to me about it at the time. Someone once told me that, your trauma is going to feel like one thing when you experience it, and then it's going to feel like something else in a couple years. And maybe if you become, if you're in a partnership and an intimate relationship, it'll feel like something different. And if you become a mom or a parent, it's going to become different again. And all these phases of life, our trauma is still there and it'll just look and feel a little bit different. It doesn't mean we're not healed. We still have to work with it.
Ingrid, so she did reply to what she did you see it? Okay.
Absolutely. So the response to what happened to that situation during a mental health crisis was the advocate had to speak over them and repeat factually that 1, they need to call a trauma-informed officer, and 2, they are escalating her trauma response to self-protect by touching her without consent. As it calmed, I asked they be conscious of consent to touch, and the survivor agreed to cooperate if that was abided by on the part of the officer until a trauma-informed officer arrived. Sounds like you really brokered a very difficult situation there, understanding that officer maybe had to be there, and then to ask for that consent and that cooperation from both sides. What a challenging experience. I'll say it again, advocates are amazing. And yes, you referred to the survivor already having a trust level with you. That is essential. I think we talked about that last week. I'm sure you've heard this in all of your sessions in this training so far, is that relationships are paramount. That's the core of what we do. It's the core of how we operate as relatives, as advocates, as community members. If we don't have a good relationship, it's difficult to do good work.
So I think this question is for you, Ingrid. Riley says, I do that 26. I go home, sleep, wake up, eat, shower, then go back to bed for the night. How did you deal with it?
I got a really good therapist and I asked for better training within my job. Because I saw you can see it sometimes in yourself, right? You can see like, I don't like who I am. I don't like these patterns I'm falling into. I come home and I have nothing left to offer my family, or my hobbies don't interest me, those types of things. And asking for that change in dynamic within my organization, or saying, hey, this isn't working for me. And we need to practice what we preach. Like, I need more time off. I need better boundaries in my work. Absolutely. Yep. Therapy and training. Absolutely.
And I just want to add, if you have the TSAS grant, there is a line in the TSAS solicitation about clinical supervision for advocates. So your advocates can get clinical supervision.
All right, out of respect for everyone's time, we're coming up on our hour, which I'm so happy about because we've been able to have some really vulnerable and intentional conversation here. Is there anything else that folks would like to talk about? Perhaps your lived experience, any other questions that you have? Brenda, thank you so much for that book recommendation. Sharing these skills are so helpful.
Thank you, Ingrid. So it looks like we're getting done a little bit early, so that's great. Since we kept you late Thursday. I just wanted to read the book recommendation for people for the recording. So it's Trauma Stewardship, and it's an everyday guide to caring for self while caring for others. Thank you, Brenda. And yes, thank you to our ASL interpreters. We very much appreciate you all. Thank you, Becky, Shayla, Ingrid, Debbie, and for everybody participating today. We understand that this takes a lot of time out of your already busy schedule. And so we appreciate you all very much. Just a reminder, we'll be meeting again Thursday, February 29th. And we'll be going over elder abuse, sexual assault identifiers. And then is kind of talked about a little bit today. So we'll have the module and more discussion on the sexual assault by self-proclaimed spiritual practitioners, and adolescents and child sexual assault will be the last module for that day, for Thursdays. So thank you, everybody. Have a great rest of your day. And we will be staying on for another half hour for any debrief. But thank you very much. Thanks.